Make coffee this morning. I made a pot earlier and all of our outlets blew. So we lost all the power in the room. So I was gonna make another pot for you folks, but I was afraid I better not do that. So hopefully we have enough coffee and there's more little pods out there for you. So we had quite an exciting morning here today. So I wanna welcome everybody to the Sierra Learning Community. Thank you all for coming. Weather seems to be holding. I drove down yesterday from South Lake Tahoe. I had a little snow, a little fog, but generally it was pretty good. So welcome, welcome, welcome. So this is the fourth in our Building Resilience series, and today we're going to focus on trauma-informed approaches, and we're highlighting evidence-based programs that address behavioral health programs in rural communities. Okay, and we have one of our speakers today is coming from Oakland, which is not a rural community, but she recognizes, and she's going to talk about wraparound services and how we can really translate a lot of what they're doing there into our communities. But our focus is as much as possible on rural communities. So everybody's in the right place, hopefully. Okay, cool. Strategies 2.0, this is our mission. It hasn't changed. We are a catalyst for building professional skills, and we do trainings, webinars. We have technical assistance projects throughout the state of California, and I'm very, very excited that I was able to, I think this is my second year now, doing the learning community projects. Everything that we do is no cost to you. Oh, I think I did. Hopefully, oh, good. Okay. And I just want to make sure that you know about all of our trainings. Carrie and Shane, my team. Yay, Carrie Collins and Shane Reserve. In addition to their technical skills, they do training for the Sierra region. And Carrie also is in charge of all the webinars for the state of California. So we host webinars pretty much more than monthly, and we have a whole series of webinars. If you aren't registered and you haven't signed up for our email alerts on the Strategies CA website, please do that, because that's the best way to know what's going on and what's happening in California through Strategies. We also have a really active resource page. We have the Building Community Resilience Volume 1 on that. We have a bunch of knowledge to action briefs on strengthening families, things of that nature, as well as learning community program. And because so many of you folks are repeat attenders, I didn't make copies for everyone's packet, but on your table is a description of learning communities, and it's a sample of the knowledge to action brief. Yes.
If I can just do a really quick commercial. We have on May 21st, we have a webinar at 1 o'clock in the afternoon presented by our ACES Connection people throughout the state. That should be a really good one. In June, we have 2 webinars, one on human trafficking, which I know is a really very hot topic that people want to know about. I don't know the exact date. And then another one is on father engagement. So we have 1 more in May and 2 more in June.
And ACES Connection will be interesting because we had ACES Connection come and speak to us last year in June, talk about opportunities to use that platform for communicating about trauma-informed care and ACES. So it's just a good refresher, because I know I always forget when I go on ACES Connection all of the bells and whistles and things that you can do there. But there's also our YouTube channel, and everything that we do in the learning communities, we videotape. The webinars are taped, and they are all available to you on the YouTube channel. So for folks that signed up for today and for whatever reason weren't able to come, or if you're looking for something to use for training, go to our Strategies 2.0 YouTube channel. Very easy to find and navigate. Excuse me, and there's a wealth of information and resources. So if you're looking for continuing ed for your staff, things like that, I really encourage you to go to that. It's really, really good. Oh, thank you. I'm sorry, I went past our funder. And of course, our funder, OCAP. And one of the things we're going to talk about today, after we have our presentations, we're very fortunate. We have another 3-year contract with Office of Child Abuse Prevention. so that we anticipate that we'll be able to continue our learning communities in the next at least year, if not further. So we're very excited about that. But what I really am hoping is that we can come out of today with some good ideas for how you all want to use these learning communities in the next year. Because everything we do, we talk about a state fiscal year. So July 1 begins our new fiscal year. Hence, that is why this series, Building Resilience, ends today. But we have the opportunity to craft learning communities any way that makes it really helpful for you folks. And we thank our funder for that, because without Office of Child Abuse Prevention, we couldn't do this. If you use social media, please post. It's a great way to get the word out about learning communities using these hashtags. And all of this is in your PowerPoint, which you have in your packets. Folks, remote sites have them, and also our online participants have access to all this material. We were hoping to start and end on time. We did get a little delayed today. Forgive me, I apologize again for our little problem with the outlets not working. I did age like another 2 years that I don't need to age, but I did. But we really hope today you'll participate. You know, it's great to talk among yourselves, but better to talk with the group. We're pretty small and intimate today, so I think we can really have a good discussion. Make sure you silence your cell phones, put them on vibrate, and then practice self-care. We don't have here the preschool operating right now, so you can use the ladies' room. You don't have to use the men's room, which for those of you that haven't been here before, when the preschool operates, we do all have to use the men's room, but we're flexible and good with that. But please feel free to get up, help yourself to food, help yourself to snacks, and have a good morning. Okay. And learning communities, as we have the Knowledge to Action brief, our goal is to increase cross-sector partnerships. So our goal is to bring folks together, bringing all their wisdom from the different entities that work in our field to come together, share your challenges and your successes, because we can really learn a lot from each other. And again, this is your learning community. So I really want you folks to take ownership in the next year. That's my goal. I've said this before. I would feel success for me in this project would be people constantly emailing me ideas for learning communities and saying, this is what I want you to focus on. This is what I want you to do. So that's my idea of success. For this year, our goal was to develop a common understanding of successful approaches to building family, agency, and community resilience, and to establish a knowledge base of evidence-based tools and interventions to build resilient families, agencies, and communities. And hopefully we were able to achieve some of that. For next year, in your packet, there is actually a handout, and it's handout number 4, and it's 2 pages, it's a front and back, and it's challenges in our work. And it has 1 column, challenges in our work, another column, what can we learn, ideas for speakers. So what I did was, let's ignore that, hold on. That's my computer saying, okay. What I did was I took a look at all the evaluations that folks completed for the past year with ideas for topics, and I put those together along with, after each learning community, I send out a highlights document to the people that participated or registered. And in that highlights document, I summarized some of the things that we talked about, things that you want to work on in the future, areas that you want to focus on in your agencies, in your communities. So I took all those and I put them together into this handout, and I want to make sure you see both sides because building resilience is the top of the second side. What we're going to do later in the day today, we're going to take a look at these topic areas, and then I've left blank spaces for you to add some ideas of your own for areas that you want to focus on. And then we'll take some time to process that, and that's what we'll do after our presentations are over today. And we'll talk a little bit about as we move forward. So this past year, we had our resilience series, and these are some of the things that we talked about. So we talked about trauma-informed systems approach. We talked about cultural competence. We talked about identifying non-traditional partners. We looked at evidence-based interventions, how to find them. If you remember at the last learning community, we talked about the Rural Information Hub, which is how I found one of the speakers today, Carly McCord, who's coming to us from Texas, talking about a telehealth program. We talked about the ACES connection, and we created an ACES community for this Sierra region. And I encourage you, if you haven't already joined, go to the ACES connection and join that community. We post a lot of good material there that I think you'll find helpful. I know Amador County created their own Resilient Amador ACES community. That's how I found another speaker, our Dodie Shepard, who's coming to us from Colorado. So, you know, we really, really worked, hopefully, together to try to identify these are the topic areas, and then I try to fill in as your facilitator, you know, who are some of the speakers you want? Where can we bring people in from? We talked about Child Abuse Prevention Month activities, and that was really, really helpful. We had folks come in from other states, and then we talked a little bit about self-care last year before the holidays. We had a video, and we talked about how important self-care is. So a lot of these topics are in this list again, because we can always go deeper, but then I also added some things that we didn't get to this year. Opioid use and suicide, for example. Disaster response, very, very critical in California right now. We only talked a little bit about self-care, and then under building resilience, there was a whole host of areas that folks identified that they were interested in. So what I'm hoping you think about today is, you know, what are the challenges you're facing in your work, and how can this learning community help you? And then once you give me some ideas coming from today's learning community, I'm going to take that information, I'm going to put together a survey monkey, I'm going to survey everyone. I now have over 200 people on an email list. People that have attended or have registered, maybe not showed up, but many of them have attended learning communities. And I'll send out a survey to them. And then I'm going to try to reach out to some of you that have attended multiple learning communities, definitely my remote site hosts, folks that are online that have come again and again. And I'm going to ask you to help me prioritize for next year. So make either a phone call, I might do a little, you know, a go-to-meeting type thing, a remote meeting. But my goal, again, is to get your feedback. I want to make these relevant for you. That's the goal. So today, we're going to be looking at those evidence-based programs. So we're going to explore a variety of evidence-based programs, including youth-serving programs. We have Dodie, who's going to talk about a suicide prevention program in Durango County. We have Carly, who's going to talk about a telehealth program. And we have Kim on site, who's going to talk about a wraparound program out of the Oakland area. Hopefully, this is going to help you all spark some initiative to develop programs yourself. Usually when we have these learning communities, one of the things that I do is at the end, we have time to network and come up with ideas that we want to take back to our work. Because I'm going to use that time to identify topics for next year's learning community, I did put in your packets, and everyone has it on the remote sites, a little idea keeper. It's handout number 6. So I'm hoping that as you listen to each of the speakers today, you think about, and we're going to try hopefully to have about 5 minutes at the end of each presentation, and have you think about, given what you've learned in this presentation, is there any component you'd like to see in your community, and what steps you could take to make it happen? Because it's important to us that you are able to take some of these ideas that you're learning back to your community. Okay, flow for the day. You're hearing me talk, and soon we're going to get to our Let's Learn presentations from Carly McCord, Kim Catanzano, and Dodie Shepard. Then we'll have our networking time where you're going to help identify those topics, and then we'll adjourn at 12:30. We have participants at the hub here in Jackson. Yay! We have Loyalton, Sierra. Do we have Sierra? Do we have a camera? I got to go all the way over here. No? Sierra's Tammy Muldoon.
Yeah, Tammy Muldoon.
Yay! Hi, Tammy. We have Serena's got a nice group, it looks like, in Inyo County in Bishop. Hi,
Hello.
Serena. Hi. And then Janelle Morales in Alpine County. I don't see Janelle, but
We
we
have
don't
two
see her
of us.
camera. Hi, Janelle. How are you?
We're
And
doing
then we
well.
have our online participants, and we're going to try to get input from them as well today on the topics that they would be interested in, because they're an important part of our community. All right. Yes. Okay, so we're going to do some introductions. The folks at the remote sites, please take about 5 minutes to just chat with your peers. You probably know each other if you don't introduce, but here at the hub, we're going to take 5 minutes and we're going to do some speed dating. Find somebody that you don't know in the room, if possible, and find out why do they do what they do. So 5 minutes, it's 9:52. We'll sit back down. In 5 minutes, that'll be 9:57 if I can still do my math. So 5 minutes, meet each other.
So if our online participants would go ahead and put into the chat box, why do you do what you do? We would love to see that. So here in the hub, we're just doing a really quick getting to know each other. People are talking about why they do what they do. Would love to hear from some of our online participants why you do what you do. Go ahead and put that in the chat box for us. Online participants are not cooperating.
They often don't.
Oh,
They're shy.
Dodie, I'm not seeing how to access the materials section. I will respond to Dodie.
Dodie.
Send you all the materials. Did you send Dodie all the materials? Yeah, she's asking for them. I'm going to just say I will ask Barb
I
to
sent
send
her
those.
the internal agenda. I don't think I sent you the PowerPoint.
I think she just wants to see all the stuff.
But I will.
Yeah.
She's in the go-to though. She can't see the material.
You just saw us today, which you heard several times. All the planning stuff. So we haven't gotten into the There is.
Oh, I won't.
Yeah, there is. We make sure we're scheduled for next year. We now know that they're every other month on the third Thursday. Yes, so we make sure to schedule that.
Oh, please. Hi, Ellen. How are you? Ellen's here. All right, we're going to come back together. We're going to come back together. Let's come back together as a group. Welcome. We have some new folks that came in. Hi, how are you? Good to see you. So before we start, I just want to draw your attention to one more print handout that we have. And we talk about this at each learning community, and it's the practice methods. This comes from the Vehicles for Change, which is the monograph that helps FRCs develop their services and their service model. And one of the things that I just hope you will think about as you hear the presentations today in particular, and when we talk later about what kind of topics you want to think about for next year, think about where your focus is and what you are hoping to achieve. You know, we have these 4 practice methods that together combined really provide that continuum in child prevention. Child prevention, we don't want to prevent children. In child abuse prevention. So we have our well-being services that are family focused and directed. We have our growth and development services, which are the educational programs for families to help them be the best that they can be and help us be the best that we can be. Then we move into the real, more community focused civic engagement activities and community development activities. So as you think about what you hear today and you look at the evidence-based programs, think about what area of focus are they on? What's your area of focus in your work? And then where do you want the learning community to focus? Okay, today we're really focusing a lot on well-being and growth and development services. Do we want to move more into the civic engagement, community development? We may not want to. You know, we may be very happy staying in that focus area, but just think about that when you're thinking about where we want to go in the new year. And with that, I am going to turn this over to our first presenter, who's Carly McCord, PhD, and she's coming to us from Texas from the Telebehavioral Health Program. And Carly, you do have to speak up so that the people in the hub can hear you. Everyone online will hear you well, but the hub folks, you do have to kind of project a lot from your office. Hi, Carly.
Okay. Hi. Well, I should greet you with the traditional Aggie greeting, which is howdy. Thank you guys so much for the opportunity to share about the work that we've been doing in telehealth at Texas A&M. we'll just jump right in. So I am a licensed psychologist. I'm also the director of our telebehavioral health programs at the Health Science Center, and I'm a dual appointed faculty member in our Department of Psychiatry, which is brand new, and also in our College of Education. So over the last 10 years, we've been building what we are calling the Telehealth Counseling Clinic. We have a tripartite mission in service, delivery, training, and research. So I'm going to share with you about our program today. Maybe my slides will advance. There we go. Training is a huge piece of what has built the clinic. I'm really passionate, one, about increasing access to care and reducing disparities, and also equipping our next generation to be ready for the future of telehealth and ready to work in rural and underserved areas. So why do we get into this? In Texas, we are 49th in mental health spending. 2/3 of our licensed psychologists operate in 5 of Texas's 254 counties. We have the largest number of individuals living in our mental health professional shortage areas. We have over 10 million Texans living in those areas. And so I've just seen time and time again how difficult it is to access care when people need it. And my personal why is my own history of mental illness with depression and anxiety. And had I not had access to therapy services the first time I experienced that in high school, I don't know that I would be here to do all this great work. And so I want to live in a world where when people need access to care, they can get it. So I congratulate you guys on all the boots on the ground things you're doing to help out families and kids in the areas that you work. So we have a lot of room to grow in Texas and our access. And then the region that surrounds Texas A&M, we call the Brazos Valley. It is all of the counties in our region are designated as mental health professional shortage areas. And our School of Public Health helped lay some really great groundwork to be able to obtain funding and launch new projects like this. So data equals dollars, right? So really good community assessments that have been done every few years return the same results. Lack of transportation. There's no centralized transportation in any of our areas except for right around Texas A&M, and just large distances that people are having to travel for their health care. Similar findings from other rural areas, low socioeconomic status, less education, some evidence of even higher rates of mental illness and depression rates in the region than we find Texas-wide and nationally. And so that really laid the groundwork for us. The how, so this is the model that we really have followed to try and establish and grow this program. It begins with community and academic stakeholder engagement. So we'll start by talking about engagement, and then talking about the partnership groups that we establish and how we organize them, how we chose an intervention, and the outcomes that we establish and how we disseminate those. So we're a big believer in community engagement, that the build it and they will come mentality is not enough. I mean, we could, from the ivory tower academic setting, say we have all this great knowledge and evidence-based tools and let us just set up shop and hope that people come. And there's just too much local capacity and local knowledge and local wisdom that improves upon what we do and what we know. It is not a complete picture without our communities. And so we spend a fair amount of time trying to stay involved in the community. I rent a huge passenger van twice a year and load my students up, and I drive them around to the towns that we serve so that they can see where our clients are living, and try and participate in outreach and being responsive to community needs. We just had a tornado that came through one of our communities, and we're able to take up a donation and go deliver that to the community. So this from the CDC had a symposium to develop some agreed upon dimensions of community capacity. And I love this switch from, a deficiency mindset to what skills and assets do communities bring to the table, because the community assessment piece always says, okay, here's all the things that are wrong, let's fix them, but here's all the things that are right that communities have available to them and can speak into projects to improve them. Okay, for us, so the next steps were to organize the partners and develop the interventions. Well, I got a little bit ahead. Actually, establish and organize partnerships to be first. So for us, the partnerships were with the county government, trying to connect with leadership, county judges, county commissioners, courts here in Texas, and just other local leaders. And also kind of looking for local leaders to point us to like non-traditional community leaders. They don't hold formal appointments, but this is the individual that everybody goes to ask about where to find X resource. So partner with the federally qualified health centers. And then on the A&M side, we had the College of Education that came together with the School of Public Health. So 10 years ago, we had a faculty member in public health go to a faculty member in College of Education and say, what do you think about having your doctoral students provide video conference therapy out to one of our rural areas? And he was crazy enough to say, okay, I'll do that off the side of my desk. And the rest is history, which I'll share about. So, and one of the things the School of Public Health helped lay the groundwork for as well was they helped the communities organize themselves into something called the Brazos Valley Health Partnership that brought people together regularly to discuss needs and discuss opportunities and keep everybody on track and moving forward. And so once that was developed, they also developed these resource center locations that were envisioned to kind of be one-stop shops where individuals could access social services like help, utility assistance, or all of the pretty much all the social service agencies are in Bryan College Station, where Texas A&M is. The food bank, the sexual assault resource center, and they can't afford to have bricks and mortar locations in all these other counties. And so having the resource center vision was that there would also be additional space in those resource centers where social service agencies could come one day a week and travel kind of around the county, but have a free place to work. And that really paved the way too for us to be able to have space to set up the telehealth unit there. And so this was my very first assistantship as a doctoral student. I just kind of lucked out and this got laid in my path. I would email my advisor at the end of every week of my first month of graduate school and say, these are the jobs that I've applied for. I still don't have funding. And so I think at the end of the first month, he said, okay, we got a HRSA grant. We're going to do a telehealth project. You can work for me. And so I really had no idea at the time all the things that I was learning to, how to go past something at Commissioner's Court to get them to pay for an internet connection, and how to work with local leaders and stakeholders. But turned into a passion. So our first site was in Leon County. That was the farthest away, the most underserved and the highest need, and had the local capacity that was ready and willing and able to jump on board and help. And then we said, well, one of the weaknesses of what we're doing is that we don't really have a strong substance use component. And so we wrote a second grant to HRSA. HRSA's been a great partner for us to say, can we partner with our local state-funded substance abuse agency and bring both of those services in via telehealth to Madison County? And that was where You guys saw the work on the Rural Health Hub, and we've grown a lot since then. So we've continued to see the model work and be feasible, and so we've looked for continued ways to grow the program. So we have those 2 sites, and interestingly, not everyone's always gung-ho about telehealth, honestly. Some people are concerned that it's not as effective as in person, which the evidence base would absolutely disagree with you. But there's definitely that sense, definitely not a great willingness or readiness of thinking trainees needed to have telehealth experience. So the College of Education said, well, this is taking up too much room at the training clinic. You guys need to figure something else out. And so because Texas had something called the Medicaid waiver, where they divided the state into regions and had a match program so that regions could decide for themselves their key health needs and design projects to meet those needs in their local areas. And so we proposed to add 3 more sites. And so that's what was interesting. That was right as I was finishing internship, and my advisor called and said, hey, things are going great. We are kind of getting kicked out of the departmental clinic. So we need to start a clinic. Do you want to come start a clinic? And so 5 years ago, I think my exact words were, excuse me, but hell yeah. And so I showed up to a clinic with no name and no real mission statement yet, and just the desire to continue to grow access to care. And so we named it the Telehealth Counseling Clinic, met all the metrics of the waiver, and so we were able to grow to have 5 access points in 5 counties there in the Brazos Valley. Just again, kind of repeating, we had a lot of the formula down for how to identify the right partners and good places to put the telehealth setup, and county judges and county leaders talking to each other and counties wanting it, saying, well, we want to be part of this. Please bring us an access point. And so last year, I got, I guess, our 3rd HRSA grant in the last decade that is allowing me to add 5 more access points in 3 counties. And so that last ribbon cutting photo is from just a couple weeks ago that we launched 2 more sites in our Burleson County. And we also switched platforms. I don't know if this is interesting. 10 years ago, we had to use high definition video conference cameras and the state's T1 line infrastructure, because that was really the only reliable broadband option to get out to some of these rural areas. Then somewhere along the line, the government deregulated the cost of T1 lines, and the cost went up 1,000%. Because the market does not really want to support T1 lines. So we had to go back to the drawing board. And we've always been able to find a reasonable solution that has sustained an internet connection, but rural broadband is a major concern. But we at that point were able to ditch the expensive units that were, almost impossible to sustain. Took out large portions of the budget. The things have evolved. There's so many platforms available on the market that are affordable. That now we have a platform where people can connect from any mobile device. They can connect from any desktop, anything with a internet connection and a mic and a webcam. So there's a potential for in-home care. I think in the next phase of telehealth, it's going to be important to have both access points, especially for places that don't have strong internet connection. You at least know that you can have one point of access that has reliable internet, or the best that you can get there. And it also helps with safety. You have a little bit more control when folks are coming into an office. But I think an in-home option is a great benefit as well. The same reasons why people couldn't get to Bryan College Station for appointments, the same reason why they struggle to get 5 or 10 minutes down the road. They don't have a car, they don't have money to put gas in their car, their physical health is so poor they can't leave the home, they don't have childcare, all the things I'm sure you guys encounter in your jobs as well. So that's our updated map of access points. And so the last piece of the model is to establish outcomes. And so that's outcomes both for our local region. How do we report findings back to the counties, which we send out monthly status reports where they get updates on how many sessions occurred and what the value of those sessions were. We're working on adding in a piece where we can say miles saved and dollars saved based on where people would have had to travel for their local or for the closest access to treatment. We want to know that it works and that our clients and patients are getting better. So we look at symptomology, we track that over time. We serve a really severe population. I mean, when you're going into rural areas where people haven't had access to care, they have, 5, 10, 30 years of untreated mental health needs. They have little access to primary care too, so they have complex physical health needs, and so those comorbidities just create challenging presentations, but also really rewarding work to know that, one, all of the evidence-based therapies that we do in person absolutely transfer over telehealth. The telehealth is really just a modality, and that people get better. People return to work. People, are no longer controlled by past trauma and mental illness. So, we found people's symptoms improve. We have one measure that picks up on physical health and mental health, and not surprisingly, therapy did not change their physical health. It still stayed on average very poor, but their mental health did improve despite that. And then I think another piece of our evaluation is our satisfaction and our exit surveys, because that's the other concern that people have going into telehealth is, will people like it? And what about your older adult population? Will they like it? And they do. I mean, there's certainly, I'm sure, people that drop out because it's telehealth and don't fill out their survey, and so we don't know. But by and large, we get really great feedback that people perceive that the services are as good as in-person services. They, over 90%. I'd recommend it to a friend. I'd return if I needed to. I felt like it helped me cope better with my problems. And the one that matters most to me is that over 90% of our clients in our rural areas say that they would have gone without services if it weren't for the services that we've made available to them. So, trying to think on the evidence base if there was anything else I wanted to stress. I guess just that there is an enormous amount of literature that to date no studies have found that video conference counseling is any less effective than in-person counseling. But I don't think it's the telehealth necessarily isn't the evidence-based intervention. We're using the evidence-based therapies that we traditionally do in person and use those over video and with great outcomes. So if that's the end of my presentation, I wanted to leave about 10 minutes for questions to hear if anybody's thought about telehealth or tried to work with universities or having success there, or just have any questions about the work that we're doing.
You want to hold that for a second? So I just wanted to thank you, Carly. That was super helpful and interesting. I did send out some pre-work. I don't know if folks had a chance to see it, a video and some articles that Carly shared with me. Hopefully you had a chance to look at those. I have these slides. Carly sent them to me. So when I summarize the day, I will include this material and you will have access to all of her slides. But I was wondering if folks could say how many counties are using some form of telehealth for behavioral health in the room. Any? Calaveras is? El Dorado, definitely. How about Amador? Does anybody know if Amador? Amador was, okay. We're using, and that's the interesting thing. One of the folks here said, that they had a full-time that they were using telehealth, but now they have a full-time psychiatrist. And El Dorado County was the same way. We in South Lake Tahoe, we were using telehealth, and then we got a psychiatrist, and we stopped, as far as I know, or maybe we use it less. But what I think is so interesting about this model is that it is so far beyond just a psychiatric consult. It's into the ongoing counseling. And don't you do group work as well, Carly?
Yes. So that's something that we've tested, both having individuals at one site, so all the group members are in the same place and connecting to a distant therapist, and also multi-site groups. And both of those have been successful because we've learned in rural areas it's hard to get 5 to 7 people with the same concern available at the same time to come, and then through our network being able to bridge to multiple locations has been helpful, and all of our evidence has shown that it's effective for symptom reduction. People feel close to their group members, even though they're not physically close.
Even if they're not physically close. So that was really interesting. I mean, think about one of the challenges we have is isolation. That you could actually do group work as well as ongoing counseling, not just those psychiatric consults that are kind of few and far between, but the ongoing. And I can see Serena, do you guys in Inyo use telehealth at all? Can you raise your hand, yes, or if you do? Yes, they do. Okay, so they do use it. And but I think what was the other thing that I think is so innovative about this project is the special training that people get in using the telehealth model for counseling. I think that's the other piece. Yes.
Yes, I hope to see that our professional organizations will do more to support and encourage our health professionals to have experience and training, because I think the consumer market is really gung-ho about using telehealth, and we know it works, and we know it helps increase access to care, and just across the country there's such a huge gap. I mean, there are very, very, very few training programs that are then equipping their future health professionals to be ready for that. So I think.
So one of our participants online would like to know, are you using telemental health with adolescents or children, or only with adults?
Yes, so we serve 13 and up. So anything that talk therapy is appropriate for, we will serve. And then when we get younger than 13, since the kiddos have a hard time still and engaging for that long without doing things together, we do parent training, or we have to refer. So there's people all across the country that are doing telehealth work with kids. There's no evidence or exclusionary criteria. The other thing is I've been the primary supervisor, and my experience ends up with adolescents. So.
Any other questions from the remote sites?
Yeah, and with our new platform, we're hoping.
Anybody here have any questions? Wait, we have a couple of questions here.
Oh.
Okay,
yeah, we have a
great,
couple,
great.
Carly. I'm going to move the mic over.
All right, go for it.
If we are able to create a rural hub for telecounseling or a substance abuse class of sorts, what about HIPAA compliance? And also my other thought is, how about billing? How does that work? It sounds complicated.
So for HIPAA compliance, there's a lot of platforms. You just need an end-to-end encryption And so if you were to look on the market for platforms, that's something that is very widely available and clear. So I don't think that's a major barrier. And what was the second piece?
Billing. How do you handle billing?
Billing. See how my brain just wanted to forget that? That's been one of the bonuses of working with a training program. I can't bill for their services, so I've had to write a lot of grants, use the Medicaid waiver program. In our next phase, we'll be working on better billing models. But telehealth is reimbursable. There's some limitations based on geography. So I think it's either Medicare or Medicaid where you have to be designated as rural for it to be reimbursable. But that's continuing to improve. There's been relaxations on whether or not you need a presenter, like a licensed presenter on the other side. I always laugh about that. Well, if you could get a licensed clinician on one side, then you wouldn't need telehealth. So I think that those are all improving. So your HRSA funds throughout the country these telehealth resource centers. So if you are interested in doing telehealth, I mean, you're welcome to email me, but your regional resource center is going to be a huge asset to that. The Center for Connected Health Policy, I think, is probably the best resource for information about reimbursement, but also just your general resource center has a lot of that information already dug up and available to you, and they're wanting to help.
And I can add some of that to the materials, the resources that I send out. I'll just follow up with Carly, make sure I get the correct websites. Yes, we have another question.
Yeah, thank you.
One more.
Yes.
One more, and then we'll move on to Kim.
In your rural communities, how did you negotiate no Wi-Fi, no internet access? And I mean, we have these communities here, lots of them.
Yeah, I mean, a community has to be ready. There has to be, so I went with a platform that has the lowest bandwidth requirements on the market. So that's one piece, is that you can pick platforms that reduce the amount of bandwidth that you need. And I mean, we have successfully implemented in a site that had satellite only with our.
Do you need to repeat? You got it. And it sounded to me like you were saying that's where you needed to have those sites throughout the region where people could go sometimes. So even though they're not doing it from their home. And me on that. Oh, go ahead, Carly.
I was saying, and reimbursement hasn't really caught up with the in-home stuff yet. We get to do that and be pretty cutting edge because of my trainees, but the hub and spoke really is the traditional, most accepted, most reimbursable, best bet for getting a solid connection model at this point.
And I would definitely suggest, I'll put it in the information, but the Rural Information Hub that we had the little tour of, the last learning community, it is a great resource for a lot of these. A lot of the topics they talk about is getting access in rural communities for internet, because it's a challenge throughout the country. So
yeah.
Thank you so much, Carly. Yay.
Thanks
to go
for having
a little
me.
girl or a little boy, somebody, a little somebody. So we don't want to keep you. Thank you so much.
Two other quick comments. One is in Inyo, the Toyabe Indian Health Project. Did I say that right? Excuse me if I didn't. Is using it for mental health.
Nice.
So it's good.
Excellent.
And then we had a question also, and maybe we can let Michaela know this on the side. But what was the church groups mentioned in your slides? So some information about the church groups.
Okay. Well, I'll get some more information, Carly, about the church groups that you were able to use. Thank you so much.
All right. Thanks.
So our next, bye y'all. I was in Austin, so I did it, you all. So our next speaker is Kim Catanzano, who is coming to us from Lincoln Services, and she's going to come on up, and I'm going to turn over the lavalier. Yeah, I think you're going to use that. And I just put it down here like that, if that works for you. Here's your little thing. Let's see, that's that. I'm gonna. And remember the 2 seconds. Okay.
So you want me to do that, make that a little bigger so that her.
Okay.
Slides in there? Yeah. There we go. How's that?
Hi, thank you for having me. Nice to see everybody. I'm Kim Cattenzane. Lincoln, we are located in Oakland in the Bay Area. I am actually the program director for their Lincoln's wraparound service, Alameda County's wraparound service. And so while we're located in the Bay Area, I'm hoping there can be some translation of what we do with what you all are looking for, because we're kind of everywhere. We work with Alameda County youth who are referred from child welfare. That was our first partnership, and it still is today. Over 10 years ago, 11 years ago, we started, and I've been there from the beginning, and had the also joy of seeing the program grow. 5 years into it, we then noticed we had a lot of kids that we were working with who were referred from child welfare, but also getting in trouble, which child welfare youth can based on their circumstances. So also ended up what we call crossover youth and being in probation as well. So with that, we started to see that we were able to be really effective with the kids who were in both systems, and then bridged into the probation system also through Alameda County. And so those are our 2 main group of youth that we work with. And again, because we travel to wherever the youth are who are Alameda County youth, that does mean often Alameda County, but it also means that we've gone to Sacramento or to Stockton or Elk Grove or just wherever just because they're in Alameda County youth doesn't mean that they're in Alameda County. And most effective to wraparound services, and like I think from the little conversations I've had here that many of you are seeing, just is being able to meet the family where they are. You know, what is it that the family needs and where are they located? So we go to the home, we go to the schools, we go wherever the need is that the family has. I'll talk about our service a little more, but all of that is just to say that we find ourselves in rural areas quite often as well. We also are partnered. Our first and foremost partnership is with Alameda County Behavioral Health Care Services. And so with that, our funding stream comes through them essentially, which is it's Medi-Cal. We're close to 80%, if not 90% funded by Medi-Cal. So the questions before regarding the billing, that is something we're always wrapping our heads around. I'll talk more to that, but that's what keeps us going. So we have to figure out how do we take this billing that's really meant for an individual therapy kind of work and bring it to wraparound work. And I think we've gotten pretty good about it, although the rules are always changing, so we're always being flexible with that too. And then finally, some of you may have heard of the KDA world, but with us being so involved with child welfare youth, you know, we were one of the first Alameda County programs also to just open up what we're doing to also help. We're actually doing the same thing. So when KDA first came around, it basically was saying that all kids in foster care system deserve at minimum one of our major tools that we utilize, which is a child and family team meeting or a meeting together with the entire family, which I will get more into, and also individual work. So it's a very wrap-like service. And so they asked if we would just continue to provide that service as well. So those are our partnerships that we have. In terms of, let me move this through. So what I will talk through is an overview of our program and what it looks like at Lincoln. Again, it's wraparound, so it's really about, it's a very flexible program, and we really want to just help the families and help the kids. So I'll describe what it looks like, but know it's ever changing based on the need of the particular family that we're working with and what it is that they need. And then I will talk about outcomes in our data, as well as, you know, make space to answer the questions how this can be most. Like I said, I've been with them since the beginning, so I've been through a lot of shifting and what is it that the community needs today might be different than what it needed 10 years ago. So that's something that might be helpful too. So our particular wraparound program that we have at Lincoln is similar to what all WRAP programs are. The goal of wraparound is really to help the youth who are the most at risk for going into group home care and to help them stay home. It doesn't mean we are always successful, and sometimes we meet those families where it's just not going to be safe for that child to be in that home, and we're working very closely with a child welfare worker and with the family, and we're letting them know that. So that does happen too. But for the most part, we're pretty successful with helping them to do that. And that's across the board. So the kids that come to us as well in probation are kids that are also at risk for out-of-home placement. These are kids, you know, with offending crimes where it might be considered that they need to go somewhere in the middle of the country or on the East Coast, you know, to be in a camp for a period of years and be away from their family and then returned. That does again end up happening, but our goal is to help them to stay home, to stay in their community, to be safe, to be in strong collaboration with probation so that that can happen. We have some kids that come to us who have come through early childhood, so that's a very prevention kind of work, but these can be kids who are also with child welfare who have bounced a lot from their home to family members to foster homes. They might be in our assessment center through Alameda County when we receive, and they've just bounced through 2 or 3 different homes, and they really want to make sure that when this little one, a 0 to 5, is going back to the next home, that it can be really sticking, right? So that they don't have to have the 13, 14, 15 placements sometimes we see with our teenagers, which we know that those outcomes can be really challenging for the kids. So that's our overall goal, just to help really work with them. We believe that the work with the family is key to that. We were just talking in the breakout group about how important the parent work is, and I think that's the heart of the work that we do. We have a 3-pronged team that's working with every family. So I'm going to get into the program here. So each family that we work with that's referred from one of those partners that I mentioned, we have a 3-pronged team that goes and meets with the family. One of those team members is the family partner, and that's actually our first person that reaches out to the family. And again, we want to have respect. We're not pulling your kid out of the home and doing therapy. What we're actually doing is going into your home as the caregiver, the parent, the grandparent, and we want to provide what it is that you think needs to be provided for your child to be successful in the home. So that is our overall intention and the first person that reaches out. So we have a family partner on our 3-pronged team. All of our family partners themselves have had what we call lived experience, where they have either had a child on probation, they've had a child through child welfare. We've had family partners who have adopted children. We've had a family partner who recently retired, who had many kids who had come through her home, some who she ended up adopting and raising to teenage years. She was our family partner supervisor. So, you know, the goal is really someone who has kind of walked that walk and then can meet with the family, meet with the parent. They may not have the same exact experience, but they kind of get what it is to, you know, how it feels to sit in a court, you know, with your kids, whether that be through juvenile justice or child welfare, how it feels to feel like the system is working against you. You still have to work with it for your child, you know, so their goal is to help with that. And also how much you are holding. And so they're good listeners. You know, their goal is to listen, to hear what's going on, to bring them and, you know, have a self-care day. We talked earlier about self-care, but just the importance of really kind of keeping yourself together so that you can be really present for the kids, you know, and how do you even carve out that time to do that when you're in that whirlwind of dealing with so many behaviors and trying to get them to do all the things like go to school that they're supposed to. So that role is essential, and it's the very first reach out to the family. We also have a community liaison, and that's the one-on-one with the youth. We have kids that we work with who are young as 2 and as old. I don't think we've gone up to 21, although we could, but at least 20, you know, 19 or 20. So we have that TAY population we're working with.
So we have community liaisons, and then they're working with probation kids, and they're working with child welfare kids. So we have a very versatile grouping of our staffing as well, in both the family partner and the community liaison. Some who have been there, done that. Many who are from the communities that we work in. You know, we have a lot of males, which is wonderful for our boys that are out there to be that male role model. We have some that are excellent with the little ones. You know, we're clear, we're not childcare, but sometimes that can be a really helpful time to take them, you know, and do that intervention at the playground, which is helping them to grow in their own skills while the parent gets a little bit time to themselves as well. Or maybe we'll go out together with a family partner, we'll get that chance to talk to the parent. So that's that community liaison role. And we had a presentation at a wraparound conference last year where we had a youth speak. And the main thing that he talked about together with his community liaison was how that relationship is what shifted everything. This was a teenage boy who had been on probation, and knowing that there was somebody in his corner at all times that could call him on his stuff too. He said he liked that. He liked that there was someone he trusted who was like a nice guy, really funny, someone he could relate to, that was calling him on his attitude and his behaviors, and he could hear it from him in a way that he couldn't the parent. And that was what the parent loved, having a person for herself too, and that was really key. And she loved that there was someone, that CL role too, that he would finally listen to. So I can't speak enough to the group of community liaisons that we have. And then we have a clinician too. We're Medi-Cal funded. I mentioned that piece. So that piece around the paperwork that's attached to it, assessments, treatment plans, you know, we have clinicians on site that are really the holders. We call them kind of the holders of the chart, making sure we're doing everything that we need to around that with our consents. So we have the clinician, but they also really hold the team together. I mentioned that we call them family team meetings. I think the common term in California 10 plus years ago when we started with that term because it is the traditional feedback that we were receiving from families, especially the kids, because children family team meetings and our teenagers didn't want to be called children. And also we said family because it's keeping them all together. It's not child and family. It's we're working with your entire family. So we crafted it a little different, and we try to hold that, even though much of our paperwork says CFT these days, because more and more people, the county's doing more CFTs. We're flexible, and our words and the way that we work. Oops.
I just kicked that.
Yeah. Yeah, about 15 minutes. Still there? Okay. So let me move forward. So that's who our team is, and what I wanted to say about the clinician is they are really sort of the glue, I guess. When I was doing that work, that's what someone called me once, and I thought that was good. I was a clinician and wraparound for a couple of years myself. And that's what they do. They're the main contact with the child welfare worker, so they don't need to be calling 3 different people to figure out what's going on. You know, so they have one person that they're building relationship with. They're the main contact with the probation officer, just making sure to give them all the information that they need and also invite them to the meetings, keeping them posted if they're not able to make it. And also them, I would say together, the whole team is contacts when it comes to community resources, depending on what the need is. But they're going to help with sort of the therapy resources that are out there, helping to translate terminology for the team or for the families if that needs to happen. So that clinician is really kind of the glue that keeps the team moving. We have some kids, in particular the little ones, seem to come with 20 different people of what we would call a formal support, and that's not including, and I'll talk more about this, but the natural support. So you go to a family meeting and you're in someone's living room. I've been to these meetings where there's you know, many people attached to the child, and that can be very overwhelming for a parent. So their job is to kind of streamline that, making sure everybody's on the same agenda and making sure that the family's voice is at the center of what that treatment's going to look like. Because you might have group therapist, an individual therapist, a child welfare worker, a mentor, lots of different people, CASA workers, that all have different ideas and great intentions. But that can be overwhelming in the example I'm thinking about, a grandparent, that's trying to just raise a child, So they help with that. They kind of tone that down and balance it out for the family and making sure the family's voice is driving the process. So with most WRAP programs, I would say they have these principles that I have here. I left a couple out that I'll add. And we're no different than that. These are the driving force of wraparound. Family voice and choice is at the heart of everything we do. So really wanting to build, and that's very interesting when you have a teenager that sees it one way and a parent that sees it another, because they're both part of the family, and that's where that relationship and strong teamwork helps a lot with, and flexibility. Sometimes you might have a meeting with a teen and a meeting with a parent and then bring them together. Often though, we want to just build communication as much as possible, because that can be where the breakdown is, especially it's a breakdown that kind of happens naturally without all the trauma that our kids have at that time anyway. So we're here kind of trying to build that piece too. But we do want the family to have a voice and to guide the process. Team-based approach, I mentioned the team. The team is our team together with the family again being uplifted throughout that. And then anybody else that they think is a help in their life. It could be a coach. We've had those meetings where we bring, that is the person that has the most meaningful and impactful voice for the child. So that person could be part of that team. Within Lincoln, where it's wonderful. We have so many services. We have some school-based services as well. We have other community-based services. So we might find that the school is one of our partners and part of the team. Also, schools everywhere. That's a major part of what we do. We sit in those IEP meetings. We help the parent, again, have the voice, understand what's happening, help the youth understand what's going on with their academics, help them have that voice and opinion in it too, and helping, if the school isn't the fit, maybe finding the fit that is there, but trying to work with it. If there's an advocate that needs to be part of that team. So again, just really assessing a lot and figuring out who are the best people to come together for this family and the child to be successful. Again, we're in the community. I started out saying that. We'll go where the family is. They do come to our office if that's more comfortable. Understanding not every family wants us to go in their home, and that's okay too. A lot of meetings at Starbucks, a lot of mental health notes written in Starbucks for our staff. Which is, again, maybe another thing. We give everyone laptops and cell phones. So the traveling piece, they kind of need to be able to do their work anywhere. We're not an office-based program, and so it can be helpful for them to be able to land places. But for our families too, we will take them to Starbucks, take them to eat, that's some of what our interventions are with the youth too, but have those meetings in a place that's most comfortable. Safety can come up a lot for us with probation youth in particular. And so then we don't stop seeing kids because something's going on. We just are more planful about where we meet them and how we reach out, and making sure that our staff are safe as well. Collaboration, I think another thing that's great is we're very collaborative with our families. Our families, for the most part, they very much love our teams. And if something's going on, we try and figure out why and what we can do better. But we have a very collaborative approach, a very kind of one-down approach of making sure the family has that voice. But also our collaboration with probation and child welfare. When we first started, the person who was on my staff and worked closely with us had most recently been a deputy director at probation, not probation, at child welfare, right? So she had a lot of great relationships that we forged and we built, and we've kept going over time. With probation, when we first started with Alameda County Juvenile Justice, we were immediately made some relationships and some connections so that we could begin being part of meetings that were right there at probation, where decisions are being made. We sit at a table where the decision is being made by probation officers about where that youth is going to go, and they're prepping for court to make that recommendation. But we're actually at the table where they're doing that preparation, and we get to have a voice and a suggestion of what can happen and when we can be helpful. We're one of 2 or 3 providers that are part of that meeting. So just being right in there in those institutions and then having regular meetings, again, with behavioral health and probation, behavioral health and child welfare. So we just kind of stay in communication and staying meeting with them. And everybody's part of setting our outcomes. We don't set them alone. You know, we make sure we're doing what probation voice in those. We have a straight. We're really with. Okay. Thank you.
Surprised none of our online people said it.
Tiers. We have 9, I'm going to say it this way. We have 9 community liaisons, 9 clinicians, and 4 family partners, and 3 people that work with each
Kim,
family.
Hold that up to your mouth, please.
Can you hear me, or can they hear me? And so we don't actually have them broken down into teams for probation child welfare per se, because every youth that comes to us and every family, we want to find the best match possible, right? So, but you can maybe do the math to see. And we work with about 90 kids overall when you add everybody together. So a caseload can be around 10 and more for the family partners. Parents sometimes don't use the family partner, and sometimes they really use them. And so we have a smaller amount of family partners because of that reason, but there's a CL and a community liaison in every case. Yeah. I think I hit all of the natural supports, the flexibility. So I can move, yeah. So I have about 10 minutes left, is that right? Okay. I'll quickly do our outcomes then so that there's more time for questions. I could talk about our program all day. So these are child welfare outcomes. They are outdated, just to be transparent, and we can send this collaboration, our updated ones, once they're done, they're due. But 78% of youth remained in the home 6 months after they left Project Permanence program. So that was done by Alameda County Child Welfare and provided to us. So that's that outcome. And then the probation one, let's see if I'm doing there. Oops. 1, 2. Okay. So this is what they're looking for in probation. 70% of youth shall have no new sustained arrest during the time of treatment to reviewed at discharge and 6-month post-discharge. 70% of youth will be living at home or a home-like setting in the community and not in congregate care at any time within 6 months of discharge. And what they found is 89% of the youth, and I hear that our most recent data, which is not out, but will be, is 90% of our youth, 6 months post Project Permanence had no new offenses. So that's a recidivism rate. It's really pretty good as far as these things go. And 11% at this time had new sustained offenses. Placement of Alameda County probation youth 6 months post Project Permanence, 75% were in the home and 19% in placement. And then the last piece, this we will not show, but if people are interested, yeah, no, it was sent out. It's a film the state did, and it's not our film, it is the state's film for their Title 4E. About 20% of our program is funded by Title 4E funds, and that helps with wraparound. There's a lot of basic needs that we're working with families around. So Medi-Cal funding, as you know, really focuses on the mental health interventions that we're doing, but we're also helping people find housing and employment and doing a lot of interventions that we see as definitely relatable to the mental health, but are a little bit more difficult to bill. And so for that, we have Title 4E. And so the Title 4E folks have come and evaluated our program. They think it's really great, so that's good. But also they had us participate in a film that they made for the state, along with some other providers. So you're welcome to check that out if you want to see a family and see it in action, what it looks like. So it looks like I have 5 minutes for questions.
Can you hear me?
Anybody have any questions in the room? Good. We have a questioner. I know. That's good.
Are your parent partners volunteers?
No.
Okay. That's really cool. I know. I love that model. Anybody else over here have questions? Questions? Anybody online? Oh, yes. Just hold.
So again, where's the funding coming from
They bill Medi-Cal too.
for the parent partners?
Parent partners are billing Medi-Cal.
What?
Mm-hmm.
Well, one of the questions is it like, as case management? Do you know
They're
the?
not billing the therapy codes or the assessment codes for KDA. They can bill ICC, which is the case coordination, and
Case
for
coordination.
non-KDA cases or the straight wraparound cases, it is the case management. They can also bill though the collateral work that they're doing. So yeah, but not the therapy codes. Yeah. Yes.
Would it be possible for you to send us some information about that in particular?
Mm-hmm. Yes.
Thanks.
And I can get that out to everybody. I'll send it out to everyone. Yeah, as a part of our follow-up.
Yeah, we believe very strong in making that role work at our program. 'Cause
Right.
it's essential. Yeah.
Oh, wait, let me run. I'm doing my Oprah thing. Here you go.
Do you work with any kind of crisis nursery?
Any kind of
Crisis nursery?
crisis nursery. I don't know what a crisis nursery is. Sorry. What do you mean by that?
It's a volunteer place that people can go and take their kids. It's a step before CPS decides you can't do it. If you need a break and stuff, they can take their children there and sign a waiver.
Like a respite.
Yeah, no, that's a good idea. Our referrals are coming straight from child welfare. And so they might, I think the closest to that is what we call it.
You have to hold it a little bit closer, but anybody else online have a question? No? All right. Thank you very much, Kim. Woo! Give you a hand. Thank you. Okay, now, oh, don't forget to look at your idea keeper. Write down anything that you'd like to follow up on, or I don't know if this is on or off. We're going to turn our program over now to Dodie Shepard. And Dodie, it runs Resilient Colorado. I also sent some materials out that Dodie had shared with us on ACEs and on, I can't remember, it's escaping me right now. ACEs, and it'll come to me. Hold on. Carrie's working on it, getting Dodie. We don't see you yet, Dodie, but we will. She was earlier, yeah. Well, this isn't hers. You need to give her the control. Oh, okay. Then, let's see. Attendees.
It's showing up on mine.
But not on this one.
What I have going on should be showing up on yours.
Oh, no internet access.
Oh.
Hold on. Hold on, we're having that's right, we're in rural California. Somehow or another, the internet. That's weird. That's strange. I wonder if I popped off of this. Here I am. It says I'm offline. Okay. Hold on. Hold on, Dodie. Don't leave us. You're fine with your internet though, right? This is strange. Yeah, for some reason my computer, you guys have internet, right? I do this, but it never tells me anything.
Sorry, everybody, hang on. We are rebooting a computer. Stand by.
This is very strange. I think. So Dodie's up on yours, but I still don't have internet.
Thanks, Dodie. We see your slide. Hang on one second, okay?
Not fixed. Okay. That's easy. Hold on, we're trying something else. Women with. Here, I think I just said this is I don't have this. I need the. You don't have this cord? It should be in your bag. I just have, this is what came with it, this little one, and I got a longer one. Is that what you're looking for? That's the same thing. No, she's got the wrong cord. Let me just try something real quick. I'm going to just try to do the old-fashioned.
I'm so sorry, everybody. We're going to take just a 5-minute break to straighten this out. So we'll be back in 5 minutes.
Okay. I am going to log off and log on again. Yeah. See if that helps. That is the weirdest thing. The internet just escaped. 30 seconds. Yeah, I have that cord. This is the cord that came with the, actually that cord came with it.
The geographic area. The focus of my master's program was in transforming youth and family culture. And we launched Resilient Colorado not quite a year ago. So we are a very new organization. We are not yet funded. We're looking forward to that happening. But we formed it to bring trauma-informed care, trauma-informed schools, and compassion without fatigue trainings to our area. There were some specific industries that were offering it within their sector, but not anything open to the community. So we collaborate with other local prevention organizations, schools, our local college, our local public health, and organizations like that. Can everybody hear and see okay? Are we doing all right?
We can hear you in the hub. We can't see you, but that's okay.
All right. So now I'm having trouble advancing my slides, and I don't, it was all working and then it doesn't again. Hang on. Well, oh, I think okay. We're getting there. Okay. So I'm going to we're going to get a bit of a drink from a fire hose today, because I am discussing 3 large subjects that are usually discussed in isolation. And my objective really is to show how they connect one to another. So I'm going to talk about the basic concept of the trauma-informed framework. And I'm using the language trauma-informed framework intentionally rather than the more commonly referred to as trauma-informed care, simply because people often take, at least in the folks that I'm working with, they think trauma-informed care and they think I'm meaning clinicians or service-oriented organizations only. So I mean it in a broad sense, and that these principles can apply to any organization or sector. We're also going to take a look at, I'm still having trouble advancing slides. Here we go. A community-wide approach to solving complex social problems, and that is the collective impact framework. And last, we're going to take a look at how that trauma-informed framework and collective impact can be utilized together to build overall community resilience. So I know this is going to be a review for many of you, but I don't want to assume that people know what ACEs are, so I'm going to do a really quick overview. I did send ahead of time a 5-minute ACEs primer video. Even if you know what ACEs are, if you haven't seen that video, it's super helpful to use with other people that don't know what ACEs are. So the reason it's so important is this study that initially happened in the early 90s, or excuse me, the late 90s, is really the background on the scientific research that initiated the development of what we now call trauma-informed care. So it focused on children, even though we know trauma happens across the lifespan. And they did have a limited demographic group that did not mirror the diversity of our community. However, it has still been a landmark study that has really changed how we approach many different challenges in our society these days. They only studied these 10 developmental ACEs, and there are a lot more. I know you all in California and us in Colorado, they don't have wildfires on that list. But not only is that a real issue for our community, but it's something that we're kind of constantly guarded against. They don't have war or homelessness on that list. So there's lots of other things they could have studied. This is just what they chose to study. And again, ACEs are not destiny, they're risk factors. So here's the results that they found in that late 90s study. But the CDC has now, the Center for Disease Control has now collected this data in 32 states, including the District of Columbia. And of those states that are reporting, they're showing that between half to 2/3 of their population has at least one ACE, and 13 to 17% have 4 or more. And the thing that this data does not show that we need to be aware of in rural communities is that those of us in small towns, people of color, LGBTQ, any minority populations, on average, we have higher ACE scores than what these results show us. There is a dose-response relationship between ACEs and adult health problems. For an individual with 4 or more ACEs, their risk out of 7 of the 10 leading causes of death in the United States is dramatically increased. So one of the things that we're working with specifically here in Durango is suicide prevention. If you have an ACE score of 4 or higher, your risk of attempted suicide is 1,200% higher than a person with an ACE score of 0. You're also 7 times more likely to be an alcoholic. So there's lots of data that goes with the ACE study, and I encourage you all to look at that when you have a minute. But the key takeaways here are that this graphic shows many of the negative adult health outcomes resulting from ACEs. They're super common. They cluster. If you have one, there's an 87% chance that you have two or more. And essentially, the way I approach ACEs is, we don't wear our ACE scores, nor should we, on our, like a name badge. But if we just assume that other people have a trauma background, then we really do provide a more compassionate service delivery. So this is a very well-known slide from SAMHSA. And again, understanding ACEs, and that's why I'm taking a couple minutes to go ahead and review this. This is critical for everyone in the prevention workforce to understand. And we see the results of ACEs almost every day. So even if we understand it, I think it's helpful for us to be able, when given the opportunity, to explain it to others. As a country, we spend $3 trillion a year on healthcare, and 75% of that cost is treating chronic disease. So if we're not addressing ACEs, we're not addressing the root cause. And in my opinion, we're missing the boat. But the good news with this study is that intervention can occur at any point along the progression, which can reduce suffering and improve the quality of life. So according to SAMHSA, building resilient and trauma-informed communities is essential to improving public health and well-being. And why is that? Because our communities are places where traumatic events occur. And they're simultaneously places that can keep us safe and restore our sense of wellness. And this is a place where I really feel like, as rural communities, we have a strength here. We know what it means to band together and build on one another's strengths and be there for one another. And so that's where I think that we can really help one another. And I again could spend a whole session talking about equity, but I do want to touch on this because it is so critical. These next two slides are from Building Community Resilience, which is a collaboration out of George Washington University and the Redstone Center. This is their graphic, and I'm providing a link to that in the resource section that I'll email to Barb later today or whenever, before she sends that out to you all. But Melody Goodman has her PhD in biostatistics from the Harvard School of Public Health. And she is quoted as saying, "Your zip code is a better predictor of your health than our genetic code." And I think there's a fairly recent development on the Robert Wood Johnson Foundation. They have a dashboard on their website. And again, I'll send you this link. But it allows you to put your address to it. And then that is targeted according to census data. And it will show you what your life expectancy is according to where you live. And it'll also show how that compares with the nation, your state, your region. And in some cases, this data varies just from one neighborhood to another, just not even a couple miles away. So as we talk about trauma and equity and resilience, we have to understand that I'm losing the word that I wanted to say, the interconnected relationship between those three things. And this pair of ACEs is also a graphic from that Building Community Resilience site. And when we talk about ACEs, we usually talk about what's happening above the ground in this graphic. But we have to, especially as we discuss equity and understand the importance of it, we have to understand that the community itself can be creating an adverse relationship. And the adverse community environment can feed into the adverse childhood experiences and vice versa. So in order to really impact this, what we are talking about here is system level change. And in other words, culture change. And that takes years. And oftentimes there's resistance along the way. And to be completely honest, as we now transition into the collective impact piece of this discussion, a lot of times, unfortunately, things have to deconstruct before we can rebuild them. And that's a normal part of the process. And it's important knowing that going in so we don't get discouraged. So a lot of times when we talk about collaboration, we think of it like a sandbox. You play in yours, I play in mine, and we're both jealous of whoever has the biggest dump truck. And I think it's helpful to, instead of a sandbox, think of it more like a symphony. There are different instruments, we all have different skills, and we all have a role to play. And in the end, what we create, the whole is bigger than the individual parts. So that's the kind of the big idea behind collaboration. And then collective impact is a specific kind of collaboration. It looks different for every community. So as I discuss collective impact, I'm going to share with you how it works in our community. And again, it'll be different for everyone. So collective impact is designed to address an urgent community need. In our case, that was suicide prevention. In other communities, they have addressed obesity. They've addressed, I'm trying to think of other things that they've addressed, and I'm drawing a blank right now. But whatever the urgent community need is, this is something that is a bigger need than any individual organization could address on their own. And it's also driven by a desire to break out of the individual silos of the siloed organizations. And this is important because issues like education, economic security, housing, health, these are not fragmented issues in people's lives, but the systems that serve them often are. So collective impact is about bringing together various services from nonprofit, for-profit, schools, government, law enforcement, medical, etc., across the sectors. So the reason our community chose suicide prevention is because Colorado's suicide rate is 3 times the national average as a state. But as a county, Durango resides within La Plata County, and our county has the highest suicide rate in the nation. And it is unfortunately the leading cause of death for our young people ages 10 to 24. So that collaborative started before I founded Resilient Colorado. So the collaborative itself is about 3 years old, and Resilient Colorado is about 1 year old. So Resilient Colorado has really benefited as an organization because this collective impact framework was in place before I got here. And we'll also talk about what some of the pitfalls are, and because there are some. So the second condition of collective impact is shared measurement. And this can be especially tough for organizations. Sometimes we don't really want to share our data, and sometimes we have proprietary data, especially if you work in a hospital or a school. So sharing can be complicated, but more and more we are learning how to share our data, and sometimes organizing assessments so that we're using a singular assessment tool rather than multiple assessment tools. Here's one example. Our local our local hospital, every 3 years, they identify top health needs for our community. And these are really heavy utilizers of our emergency room and health needs that they think that they can impact as a hospital. And they identified 5 health needs that they want to address over the next 3 years. And of the health needs that they addressed, all 5 of them are impacted by ACEs. Now that's, when the hospital is announcing this, they're not saying that there's an ACEs connection, but those of us that are in upstream prevention understand. And those top needs were obesity, mental health, alcohol abuse, suicide, and for the first time ever in our community, oral health. And when you look into the data on ACEs, it's quite compelling about the relationship between ACEs and those negative adult health outcomes specifically. So the next condition of collective impact is mutually reinforcing activities. And this is another area where I feel like as a rural community, we have a unique advantage to affect this. We naturally are better, I think, at coming from a big city and moving to a one-stoplight town. We are naturally better at supporting one another's activities and programs, sharing our resources. But in collective impact, this is a super critical piece of how this all works. We coordinate and synchronize our work across agencies to ensure that our activities and programs are accessible and comprehensive, and that we're not duplicating work. So in our case, we found that the Department of Public Health and one of our local prevention organizations, they felt like they were duplicating efforts. So they decided, instead of doing the same work separately, they decided to form a new organization together. And that organization is now called ROAR, and that stands for Recognizing Opportunities Around Resilience. So Celebrating Healthy Communities was the prevention organization, and the County Public Health Agency have come together to form this new organization, and all of us in the Suicide Prevention Collaborative and other collaboratives in our community are working together to support the activities that ROAR is doing, and simultaneously ROAR is supporting our activities. So that's a bit of about what that mutually reinforcing activities can look like. It also can look like collaborating when it comes to funding opportunities. And that's a wonderful thing that we're really just getting started with, but we're seeing some promising results. So the fourth condition of collective impact is continuous communication. And just like with any organization, this can be super tricky. We utilize Basecamp and newsletters and social media, but it's still a challenge. One piece of continuous communication that is also important beyond just, communicating what's going on in the community is building capacity around common language. And as an educator and trainer in our community, this is a huge part of what I do. And obviously, the Backbone organization supports that, and we'll get to that in a minute. But one of the things so we provide, at Resilient Colorado, we provide trainings to both adults and teenagers about trauma-informed care, trauma-informed schools. We have a training for caregivers called Compassion Without Fatigue. And we've developed a training specifically for teenagers called Resilient Mind. And as we're talking about ACEs more and more, other organizations are starting to talk about it as well. And one example of this is Resilient Colorado was offered the opportunity to do a training at a local high school back in November. It was just a 2-hour training with a group of seniors because they had chosen for their senior project to do a Communities of Resilience initiative, and they wanted to destigmatize mental health and suicide specifically. And they brought in Resilient Colorado to provide this language piece to help them with this community project that they wanted to do. And so back in November, we did this training with them. And then I just found out just last week that those same group of seniors are now utilizing the language of ACEs and the science of resilience. They're utilizing that language in their senior project thesis, senior theses, and their college applications. So I think that that's a tremendous evidence of not only what Resilient Colorado has been able to do, but also what our community has been able to do and their teachers to reinforce a training that happened for them months ago. So when we talk about collective impact, there are a lot of moving parts, and all of this has to be coordinated. And that's where the backbone support agency comes in. For us, that is our local public health agency. It's not always a local public health agency. It can be lots of organizations, but somebody has to be driving this effort. And whatever organization that is, they need to be selected by the community. They need to be trusted by the community. And they need to be large enough and flexible enough to convene and coordinate and align all of these efforts and understand what's going on in all the different community organizations and kind of help bring us together. And, you know, it really requires a special skill set to be able to bring these siloed organizations together. And I'll get to some of those pitfalls again here in just a second. But the other thing that the Backbone Support Organization is starting to do is they're coming back to Resilient Colorado now and asking us to provide trainings, and this is where that Compassion Without Fatigue training specifically plays in, because that training is focused on secondary trauma, compassion fatigue, and burnout, and intrapersonal boundaries, and how to prevent compassion fatigue, burnout, secondary trauma, and how to prevent it, how to identify it, and what to do if you're in the middle of it. And that's really about supporting the people in our community that are doing this prevention work. Again, specifically around suicide, but all sorts of prevention efforts and intervention efforts. So collective impact is messy work. When I first began to learn about it, it reminded me, I have 3 teenagers, and this reminded me of what it's like when, you know, I really would, it'd be easier if I just cleaned up the mess on my own, right? But we also know that in the long run, it's not best. And in fact, this is one of the ways we build resiliency in our children. So collective impact is hard work, it's messy work, but the trauma-informed framework can really help. And some of you will be familiar with these principles. They come from the work of Roger Fallett and Maxine Harris. And you can find more information about this on SAMHSA's website. And again, I'll provide that link in our notes here at the end. But the first principle, and this is where the biggest pitfall is with with collective impact, it's safety and cultural humility. Safety is paramount. And one of the issues that we had in our collective impact efforts in our town was that we did not take the time to build trust between different organizations. And in fact, there was an extended period of time where we had to put our collective impact initiative on hold simply to go back to ground zero and build the safety and cultural humility piece. So by safety, I mean literal safety. We can't have the roof falling in on us while we're meeting. We can't have wildfires taking over our meeting places. But this also includes racial, ethnic, religious, gender, and sexual identity and safety around those issues. So it's super critical, and our collective impact results won't get off the ground without taking this seriously. And alongside that is the concept of trustworthiness. We have to get to know our neighbors, what their values are and what their passions are. And again, this collective impact work, it is so messy and there will be conflict. So we have to have this foundation of trust and safety to fall back on. And this concept of trustworthiness also impacts how we communicate. We have to be clear and model appropriate boundaries and create norms for interaction that promote reconciliation and healing. And these are the ways that we model within organizations what we're trying to build in our communities. And that's also how we build resilience. It's kind of an inside job that then affects the community simultaneously. So the next concept of, the next principle of trauma-informed care is this idea of choice. And we need to maximize choice. And part of the critical way that we do that is we address how privilege and power and historic relationships have impacted the perception and the ability for other organizations to respond to the choices that were offered. There's power structures within these profit, nonprofit, and government organizations, and so we have to address that head on. Obviously, the idea of collaboration is just critical to the whole idea of collective impact. But specifically with trauma-informed foundation or framework, we honor transparency and self-determination. We seek to minimize that power differential that we're talking about. And really, when it comes to collaboration, the way I like to think about this is I like to picture a typical high school cafeteria. Think back to what your school cafeteria looked like. At least if it was anything like mine, we had, we had the table for the jocks, the cheerleaders had a table, the band geeks had a table. The brainiacs, they had their table too. And when we work on collective impact initiatives, every single one of those tables that you see in a high school cafeteria need to have a seat at our collective impact framework, our collaborative. Here's one example. I just recently learned that 12% of our county is Spanish speaking only. And we do not have anyone in our suicide prevention collaborative that's Spanish speaking only. And so when we don't take careful note of who's missing at our collective table, we run the risk of doing that group of people harm because they're not represented in the work that we're trying to do. And in addition to the other agencies that we're working with, we also need people that represent who we're trying to serve at that table. So in some cases, that involves youth. If you're serving the homeless population, then you need homeless people to at least have a way to give their voice to the initiatives that we're talking about doing in the community. And all of this really comes together in an empowering way. And empowerment is a critical principle of trauma-informed care and the trauma-informed framework. And it's exactly how we build resilience, both in our workplaces and our communities, as we build on one another's strengths and we encourage and help build one another's skills. This leads to deeper community engagement, and it leads to healing and recognizing and responding to the impact of not only historical trauma and oppression, but the current traumas that happen in our communities. So I know that was probably a drink from a fire hose. I hope you have a bit of a better idea how those different ideas of the trauma-informed framework, the collective impact, and equity all play an interconnected and critical role together to build community resilience. And I'm going to leave you a bit with a takeaway, and Barb may sort of take this in another direction, but my encouragement to you all is as you work in your learning communities today, and oh, by the way, I think what you all have going on there is so exciting, and I would love to build something like that in our region. I encourage you to brainstorm who some people are that you could collaborate with, who are organizations that either have a similar mission to yours or are working with a similar demographic, and what's some low-hanging fruit that you all could harvest together. How could you complement one another's strengths, and how can you begin to build relationships with those people and begin to make a plan, an action plan for how to reach out and connect. So I'm going to try to pop over into the chat and see if there's any questions. I don't know where we are time-wise because of the delay. I don't really recall when I started.
We're not sure either.
No, we're okay.
Okay.
We're
We
good
definitely
on
have time
time.
for questions. And I just want to let the folks here in Jackson in the hub know, we will have a link to the recording, so you will actually be able to see Dodi's presentation, and I will also get you the PowerPoint as well. Yeah. So after it's over, but unfortunately, Dodi, that was excellent. But it was like listening to Terry Gross on fresh air.
It was.
Right?
I
It was
agree,
relaxing,
Barb. I agree.
just having to listen. So I'll start in the hub. Does anybody have any questions for Dodi in terms of a project? Let me run over. Hold on. Well,
You have to
nobody
use
else
the
can hear you
microphone
if you
so
don't use
people
the
can hear
mic.
you.
No.
You had mentioned a very quick video on ACEs. Could you?
Yeah.
Sent that out.
You did? Okay.
Yes.
Thank you.
Is that the one that you
And
sent that to me?
It is. And Barbara, I have a question. When are you going to, I have a list of resources. That ACEs primer video, it is fantastic. It was done by the people that did the Paper Tigers movie. And I've got it in my list of resources also. So it's going to be double. You'll get it twice.
Yes.
When are you sending that out to your team? Because I need to get you my PowerPoint. So I can do that.
Right.
Can you do that today?
You just send me the PowerPoint whenever you're convenient. And then the next week, I usually get out the highlights. But I did send out the ACEs primer to everybody. And if you didn't receive it for whatever reason, let me know in the pre-work.
I believe it is KPRJ Films. Let me Google that really quickly.
And also she had a really
ACEs
great
primer.
collective impact introduction as well that was in that.
Yes.
So if anybody needs that, I can resend it. But I'll put everything together in one highlights document.
Sure.
Anybody else here have a question for?
Colorado?
Oh, Durango.
Durango, okay.
Durango is the
Lovely
far
area.
southwest corner. So we're less than an hour from Farmington, New Mexico. So we're in the southwest Four Corners region, Colorado, Utah, Arizona, and New Mexico is the Four Corners region.
Dodi, I was curious to hear, so the severe issue that you're dealing with is suicide in your county. How did you, as a group, where are you with that now? I mean, what were your first couple of steps? How did you decide on those?
Well, so the Suicide Prevention Collaborative that the backbone is driving, as I discussed, that started before Resilient Colorado really, well, actually, now that I think back, it was kind of simultaneously. They had been talking about starting it, and the state, at a state level, they had selected 5 counties to work towards suicide prevention efforts. And what the state is trying to do is they're watching our collective work as these different counties. And 2 of the counties are side by side down here outside La Plata County. And so they're hoping to come up with some solutions to, and I can link to this too. I believe it's called Project 25, but let me get you the link. But it's to reduce suicide by 25% by the year 2025. I think I've got the numbers right there. So the state initially selected La Plata County as one of these focus areas. And then we had what really pulled me into this work with trauma-informed care was my own children had lost 5 of their peers to suicide in about 14 months. And that sounds dramatic and horrible, and it is typical of our what we're dealing with in our community. That picture that's on the screen right now is of a local high school there at the top, and that's a group of seniors that I was talking to you about. And every single one of those students has lost a peer to suicide. Most of them have lost more than one. So it is a paralyzing issue that our community is dealing with. And it was really community outcry is, I think, is the short version. Community outcry coupled with a state initiative, if that answers your question.
It does. Thank you. I just was curious. That just sounds like such an overwhelming issue. And so good on you for trying to contribute.
It is.
Any questions for Dodie from the remotes or the online people? No? All right. All right. Thank you so much, Dodie. I'm sorry we couldn't see you here in the hub, but everyone will get a link to you. And thank you so much for your time, and I'll be in touch with you.
Wonderful. Thank you. I hope you have a great rest of your meeting.
All right. Thank you.
Bye.
Yay. So now we're going to turn to the part of the meeting where if this would be on the screen, but it is in your it is in your PowerPoint, and the online and remote folks can see it on the screen. So it's 1:45. We're a little bit late. So it's 10 to 12. So maybe for the next 20 minutes, and I did put out some new snacks here. There's some dips and more fruit, so to keep you going. So for the next 20 minutes, if you could get together, since we're a small group, maybe like this table match with that table, and that table match with that table, and that table with that, and then just try to answer the question. It's in your PowerPoint. What issues or challenges are you facing in your family strengthening work, and how can the learning community help you to meet those challenges? And what I'd like you to do is try to, as a group, come up with like 2 or 3 top areas that you would like the learning community to focus in on, that you'd report out. And don't forget, you have the handout, I think number 4, that lists all of the, start with handout number 4 that lists all the areas you've already identified for us through your evaluations, through the highlights. And then don't forget the back, that's really important, because we've got the building resilience. And then what are, you can pick areas from there that you think you'd like to continue or focus in on, or you can add ones that I've missed. But what I'd like to see is if we get some consensus. That's my ultimate goal from the groups of areas that you'd like to focus in on. So we'll get back together at 12:15, get some snacks. And it's raining, so you can't leave anyway. At least it's raining here in Jackson. And thank you all for your patience with our troubles today.
Okay, I have started recording again. We're losing all of our online people. I'm down to only 2 valiant people that are still online with us. So hang in there, because now we're going to share the things that we're So Inyo County shared some of their challenges that they're dealing with is substance abuse, prevention and treatment, emerging focus on opioids, including increasing conversation, focus and funding, mentoring, increased demand for mentors and need more male mentors, providers and programs for young adults with developmental needs locally instead of sending away to services. So that is some of the challenges of Inyo. Now I have a couple of other people online. I have Cecilia and I have Michaela. If I unmute you, I don't want to put you on the spot, but you are now unmuted. If you have anything you want to say to the group. And I guess not. Okay.
Oh, can you hear me now? Okay. I will repeat that. Our first out of the 3 challenges and ideas would be the transportation for our rural areas. We need to figure out good times and people that will be available to take the public transportation bus. The other challenge, of course, is like many others, is internet access in our rural areas. And our third one is trauma-informed care, self-awareness of service providers.
And there was a great NPR segment about this rural community that instead of investing in public transportation, invested in Uber. And they gave people Uber vouchers, right? Great idea. Well, it worked so well, they ran out of money. They ran out of money because people loved it. People are like, this is great because it's on demand. It's, door to door. It picks you up quickly, but they had to stop doing it because funding was an issue, but it was interesting. Are you your own group? Okay. Who wants to be the representative? You look like you are. You just have to speak into that. You'll do it.
Okay, which one are we doing?
So if you could just try to pick out like the top one or like 3 out of there of your challenges and some ideas that you might have had for some topic areas.
I'm just curious, what's the status of upgrading? What do I want to say? So I live in Ventura, and there's been a lot of the road. They've had the roads torn up around my house for the past month or 2 because they're putting in new
fiber optic.
So I was just curious what the status of that is in other communities, maybe.
I would say not up here. No. Right now, I think a lot of things that legislation, like fighting to have the rural community boards.
But that may be an interesting topic area.
So we were just saying something about what the status is of upgrading fiber optic technology into cities. I live in Ventura, and the streets around my house have been torn up for the past month or 2 because I know they're putting in new technology for that. And the folks in the room say that's not happening in the Sierra region. So, okay, thanks.
Things that we talked about were also the male mentors, after school programs such as sports or activities that the kids can go do, and also low cost or no cost activities, because it is such a rural area and we don't have a lot of money that can go towards those things.
And you had also transportation.
Yes.
So you could just check. They had 3 of the same: transportation, internet access, and trauma-informed care. So that's agreed. Excellent. And then our last group, who wants to be the speaker? You have the paper.
These were just my own thoughts, though.
Oh, okay.
We didn't really discuss
You're a mind
them.
reader, so it works out great.
Oh, okay.
Here, you want to just speak into the mic?
Okay. So one of the things that I just kind of came up with was, and talking about Uber for transportation, is that Medi-Cal reimburses for transportation, and I just wonder if they would include Uber or Lyft. So that's a question I'll take to my county. But also just the lack of male mentors, big brothers, big sis, big brothers, male therapists, male. Yeah.
Like we have one male today.
I know.
Look,
I know. Yeah.
Example.
Yeah.
And one of the areas that we had talked about as a team, for how many folks here were here for Oscar Perez's presentation? So not that many. Were you guys here for Oscar Perez's presentation? Yeah. So I'm wondering, when I hear this male mentor, I wonder if it would be good to bring him back in to do some, help us work on that, because that's one of his areas, is really bringing community members in and he worked with the Family Resource Center down in Kings Beach on developing mentoring programs and family programs. So that may be a good way to, he's actually he's physically
Nevada
located
City.
in Nevada County in Nevada. Yeah, he's really good, and he did a nice job, and we would like him to do something more experiential for us. So we'll have to think about that. I'll talk to him.
Barb, I'm curious, what does this mean? Trauma-informed care or self-awareness of providers?
That was your group back
that
here.
was the back group. So what was the concern about that, or can you tell me some more about this one?
The trauma-informed care, self-awareness for providers.
We both can. Yeah, I mean, just, service providers, I mean, using self-care and compassion towards themselves, because if they're not, that's reflected on how the service is being provided, how clients, patients, participants are spoken to, how they're treated, how they're helped. Just more self-awareness on that. Almost like basic customer service skills, maybe.
So like customer service skills for social work, or family serving.
How to make people feel welcome.
Okay.
A warm environment.
All right.
I think you can extend that also to CPS, to Health and Human Services, to our law enforcement, to our judicial system, to our DA's office, our schools.
Everyone, basically.
Our schools, including teachers and everybody that works at a school. I mean, that's kind of, I think.
Providing a service to anyone in the public.
Excellent. Thank you. Oh, we have somebody popping in.
So Michaela is in Inyo, and she says, I've only been, I did get cataract surgery, but I still have a hard time seeing this tiny print. I've only been with Inyo for about 2 months, but I've noticed as a challenge is getting the right information to the right people.
Absolutely. And that's another area where just another plug for ACES Connection, and as a way to collaborate and work with to promote it among all these other partners, the people that are like the judiciary, the probation, et cetera, trying to get those folks, it's a first step, get them signed up so that they can begin receiving information, and it pops in your email box, and sometimes it's very interesting. And then the other area of the broadband, there's a lot of information on that Rural Information Hub about grants that come in for broadband expansion. So I would encourage you to go to that Rural Information Hub. If you just Google that, and I'll send it out again, you can set up, and we had a presentation on it, but you can go in and you can get specific alerts about the areas that you're interested in. So and it pops up in your email again. So I kind of like scan through it, and I might click on a few, but it's a really good resource. And it's a great way to learn about grants that are available. They focus a lot on federal funding on that site. All right, anybody have anything else they want to add? Well, I want to say 2 things. One, thank you so much for your patience with all of our strange, I always worry about something because I'm a worrywart. Today, the losing power and my internet just popping off my computer, I've never worried about those things. So there you go. No, it just reinforces what's to worry, because you always worry about the wrong stuff. So thank you for your patience. Don't forget to do your evaluations, and
hold on, Barb, hold on. Carrie has something to say.
So I was trying to come up with a poem, and all I could say is, this is my friend Barb DeGraff, who always makes me laugh. And that's as far as I got. So we just finished a 3-year grant, and this whole learning community thing was a brand new thing, and Barb got me as her support person. The person who is more scared of technology than anybody else on the whole strategies team. And this is what they gave me to work with, but Shane is my my Prozac. And this is all being recorded, I think. So, and the good news is that we got renewed for another 3 years. So we're really excited about that. But I wanted to thank you for taking me on this journey with you. And one day, Barb said to me, Carrie Collins, I trust you. And that was like the nicest thing that Barb could say to me. We've been through a lot this last year. So I got you a little book called Daring Greatly by Brene Brown, because I think that Barb dares greatly. So thank you for being our partner, and here's to another 3.
Academy Award. But thank you all for being a part of this. And I am going to be reaching out to folks to really, further hone down ideas for next year. So don't ignore my phone calls or my emails. But thank you all so much, and drive safely in this weather. I'm going to drive very safely today because I think there's ghosts in the machine.